Ben, so lovely to have you back on the podcast. I think we're going to talk about therapeutic diets today, but more generally, what are the foods that boost and repair the body, reduce inflammation, and by nature are anti-aging?
Yeah, it's a big question. There's a lot of different foods across the spectrum of what we eat that contribute to anti-aging in the sense that they optimize health and help prevent age-related chronic disease. And you can break it down into like food groups, at a top level, and then you get into specifics. But at food groups, it's really clearly, fruits and vegetables, but specific categories within that in particular, are really rich in nutrients that support metabolism and optimize function. And the real key standouts are things like the green leafy vegetables and berries and things that are really rich in polyphenols and phytonutrients as a starting point.
Yeah. We just did some work on berries, actually, doing a deep dive into the benefits to brain health, cardiovascular health, even blood sugar as well. It's actually some really interesting interventional studies as well as observational data looking at the benefits of just getting berries in every day.
Yeah, absolutely. You're 100% right. And it's, there's sort of levels of data that point to these foods, like you say, the observational studies. And then there is a surprising amount of interventional stuff, especially on berries, and the effects are really striking, like in terms of optimizing metabolism, blood sugar regulation, cardiovascular health. And one area I find really interesting is like cognitive function as a biomarker of like brain aging, right? And there was a great researcher, she's unfortunately passed away now, that Martha Morris, who pioneered what they call the MIND diet, MIND, which is a version of the Mediterranean diet that's been optimized for brain health. And it was actually her work that really isolated, in a sense, the benefit of these particular foods. The green leafy vegetables weren't so much on the radar before her work. And they actually developed a metric for looking at how much these foods can shave off your brain aging, basically like years. And when you look at the green leafy vegetables, it's like nothing comes close.
Wow.
And then a bit behind that's the berries. And then it's things like nuts, walnuts in particular, almonds, things like that. And so like thanks to that sort of work, we've got a good idea on what's particularly good for you.
Yeah. That's amazing, isn't it? Because I think a lot of people are looking at cool and sexy additions that are like adaptogens and specific types of drinks. And we have this thing in the doctor's kitchen: just get your daily BBGs, beans, berries, greens, and seeds and nuts.
Perfect.
If you get your BBGs in, you're good.
That's the thing. Like, and this is the one of the things that infuriates me as someone who works in this field is there's all this hype around like superfoods. And I'm like, hang on a second. There's so many cheap, accessible, local superfoods that aren't being hyped that you need to know about. Right. And BBG is a great way to do that.
Totally. Yeah. So we're going to talk about therapeutic diets, right, for gut health. I think you did this wonderful presentation at your nutritional medicine conference that you hold every year. But I guess before we dive into specific therapeutic diets, why don't we talk about gut disorders and specifically which diets have perhaps the most evidence for use in gut disorders?
Yeah, absolutely. So I think a good place to wind it back is to define what we're talking about. And, gut disorders mean a lot of different things to a lot of different people. But like medically, you can break these into categories. And one of the most common ones is something we call IBS, which, isn't a very helpful term, but what it's defined by is like pain, bloating, discomfort, changes in bowel habits. And I think an important thing for people to understand is that this can be really severe for some people. It can really impact their quality of life, daily function, and be hugely problematic, leading to things like anxiety, fatigue, and so forth. So you're not just talking about a little bit of bloating here. It's something that can be quite impactful in people's lives. And that is a broad category that, and this is one of my things with gut disorders is it can be broken down into different areas. So although we've got this general category, they're almost like subtypes of IBS that we need to be talking about, especially in relationship to what diets work.
Totally.
Because there are different causes for the same set of symptoms. And this is one of the problems is that this is often overlooked. It's like, you have these symptoms, you have other serious problems ruled out medically, and then you're sort of lumped with this diagnosis, and you're told, maybe take a probiotic, try and eat better, and there's not a lot of solutions.
Yeah.
So,
and actually, anyone listening to this, whether they're a medical professional like a general practitioner or a patient, probably recognizes that chain of events very well.
for sure.
So you go in, you have these really debilitating symptoms in a lot of cases. I think most people have come to understand IBS as bloating-like related symptoms, but there are lots of different symptoms related to irritable bowel. And then you go through all these barrage of investigations, in some cases as severe as having an endoscopy, as well as bloods and everything else. And then everything's quote unquote normal, in which case you're carted back to your general practitioner, and then there's not really much else.
Right.
So this is sort of the lay of the land. But
yeah, exactly. And it's not controversial. Like you say, everyone knows this, from the gastroenterologist to the doctor to the dietitian to the patient. It's a common experience. And speaking to this, I had a paper published in the journal Gastrointestinal Disorders with a provocative title that was, Does IBS Exist?
I wanted to talk to you about
this.
Yeah.
Oh, cool.
It's a great title.
We're heading there. And that title helped. Actually, it got that paper a lot of traction.
Gotcha.
Because it was intentionally trying to stir things up a bit. And the whole premise is that actually there are things that we're often overlooking within the workup, or I should say assessment of IBS, that we could be doing that we're not currently, that can identify underlying causes that have diet and lifestyle related solutions, or not necessarily a solution, but things that we can be doing to support symptom reduction and management.
For sure.
So I think this is a huge area that, is coming out of the woodwork around better management and better support for people who are suffering from digestive symptoms.
And looking a little bit further into the various subtypes of IBS, can we qualify some of them for folks at home? Like, what are the predominant symptoms of different subtypes of IBS?
Yeah, absolutely. So the way I see it is there are like two sets of subtypes. There's the traditional ones that are that everyone working in this field will know about. So this is diarrhea predominant, constipation dominant, like mixed type, which is a bit of both, and then there might be pain. There's a few different versions of it.
Yeah,
but they're all
pretty broad, aren't they?
They are. Yeah. And they're a little bit useless in that often people who have constipation will alternate with diarrhea and will get pain, and it will change. And so you need to be careful with these classifications because they're dynamic. And the other, and this sort of comes back to some of the work that I've done, is that I think there are subtypes based on identifiable contributing factors to people's symptoms. So, an example of this might be, we have some emerging research to suggest that nickel in the diet, which is a metal, could be contributing to symptoms for some people.
Wow.
So the way I see it is this is potentially a subtype of IBS, is you have like a nickel sensitivity subtype. And this is one that's definitely being overlooked for good reason. It's very new work that's being done in this area, but it's really important. And there are reoccurring things around this. It's like, it could be this, or it could be a food sensitivity of some sort, and so on and so on. So, yeah.
Yeah. And in terms of the traditional diets that are used for IBS, why don't we go through some of the general approaches that people have when they have either a specific subtype of IBS or other symptoms?
Yeah, absolutely. So there's, like, currently within the UK, you sort of conventional management of IBS, there are two main dietary approaches that are utilized. The first is what we call a BDA, or NICE guideline diet. It's also sometimes referred to as a traditional IBS diet or a traditional diet. And to define that, essentially what it means and what the approach involves is some really simple practical things that people can do that we think are very likely for most people to help reduce symptoms. So that is like, regular meals, eating healthier, avoiding things that can cause excessive gas, like excessive intake of onions and beans and so on. And excessive alcohol, these kinds of things. They're fairly simple, logical, easy to apply things. And that approach has really good evidence behind it, works very well, and is generally recommended as the starting point. So if you have symptoms and you're thinking of embarking on a diet, this is where you want to start.
Start with that.
Because it's easy, accessible. It's not going to change your diet too much, and it might work. There's a high likelihood. So before you get into some crazy, extreme diet, start here.
Start really,
right?
Yeah.
And then the next tier in the conventional management is what we call the low-FODMAP diet, right? And that's a lot more involved. So it really requires care and assessment with a nutrition professional like a dietitian, and careful management through the dietary process. I mean, you can do it yourself. There's lots of DIY versions.
Totally.
And, self-management's not necessarily a bad thing, but good to have care and advice because it is quite restrictive, and it's, important to be coached through that. And that diet basically involves restricting certain types of carbohydrates that are easily fermented by gut bacteria and produce gas. And it's not that the FODMAPs just cause gas, it's that the gas actually has other effects other than just causing farting. It actually aggravates like the nervous system, and it can contribute to a lot of the symptoms we see, like constipation, but also diarrhea, and also pain, and also the feeling of like distension and bloating and so on. So, and probably other things like like even mood and fatigue might be affected. So
I was going to ask you about that, because there's this term that I'd come across after chatting to another podcast guest, Monty Lyman, who's written a book all about the immune mind and how our microbes and our mind and our immune system are all intimately linked, as you well know. And he described something that he suffered with, which was an irritable bowel, which led to an irritable mind as well. And so this connection, with not just traditional digestive symptoms of constipation, bloating, diarrhea, and alternation between the three, but also mental health symptoms that perhaps might go undiagnosed or not picked up on as being related to an irritable bowel issue, unless, you had a practitioner that was holistic minded.
Yeah, exactly. And I mean, this is you well know, is like one of the great conundrums in medicine really, is that it's difficult to compartmentalize things and ignore other areas of the body because it's all interconnected. So, you frequently, in medicine, we call that a comorbidity, which is a silly term in the sense because it's just the person, and it sounds wishy-washy, but I think we need to get back to like holistic medicine as a term and start thinking about how everything interconnects in the whole body and the whole person. It's because that is what happens. Like we know in IBS, there's frequent comorbidities of anxiety and stress and sleeplessness and depression and so forth. And we also know that it's not just because you've got horrible symptoms, it's because there's a biological relationship between the two.
Totally.
And, there are ways we can explain that biologically, like the gut-brain axis or the effect of certain foods that could be aggravating both areas, like your mental health and your gut health could be affected by the foods that you're eating, and so on and so on.
Yeah. Before we go into the FODMAP in a bit more detail, I wanted to ask if you had an idea, like a ballpark idea of how effective the traditional diet, or like a NICE or BDA standard diet, is for IBS symptoms.
Yeah, it's a good question, and I don't know. It seems to have a statistically significant effect when you look at it in the research, and generally it appears to be quite comparable in effectiveness to the low FODMAP diet.
Okay.
So there have been quite a few head-to-head studies, and the efficacy seems similar, and that I can speak to is the low FODMAP diet has like about they say 80% of statistics are made up on the spot, but it's about there's a really good response rate.
Yeah.
But it's about 70% or so. So there's like 1 in 4 people roughly that don't respond very well to a low FODMAP diet, which I think is really interesting, and we can come back to that because it opens up that question like, why aren't they responding? But yeah, the take home is that there's a reasonable chance that you are going to respond and you'll get a decent symptom reduction.
Yeah, from a less extreme diet that isn't going to be, putting you potentially at risk of, not getting a diversity of different ingredients.
Right.
You actually had this amazing slide from a journal of gastroenterology and hepatology that we'll put on the screen for folks on YouTube.
Cool.
But there's this head-to-head comparison of traditional diets versus low FODMAP diet and a gluten-free diet, and I thought that was really impactful when I saw that on the screen when you had up on your presentation.
Cool.
Just to show the comparable efficacy of something. But what isn't demonstrated in that is just how restrictive one is versus the other. And so you want to go for the sort of like the lowest barrier before you start going to the more hurdles.
Yeah, for sure. And I think I love these kinds of studies, like comparative studies, because you're comparing possible interventions against each other and looking at things like efficacy, but also, and you really astutely point out, is like the real world things that matter. Like, it's not only about efficacy, it's also about acceptance with the patient and the easeability of implementing it. And this study was a brilliant example. Is there was almost comparable efficacy, but the traditional diet was way more acceptable because it's so much easier to do. And there have been other examples where they compare head to head, like a gluten-free diet versus a low FODMAP diet versus a Mediterranean diet. Which do you think wins? Well, efficacy, they're all similar, but people love the Mediterranean diet and we're much more likely to stick to it because it's way better. Like, it's like about abundance and inclusion rather than exclusion of foods, right? Yeah. So it's like a very different way of approaching things, and it just makes sense.
Totally. But, you described the FODMAP diet, something that basically went viral when it kind of came out, because I remember first coming across it. I think I may have been in Australia, and it came out of Monash University, I believe. And it just got wildly popular really, really quick. But I guess maybe before we talk about the FODMAP in a bit more detail, what is exactly a FODMAP for folks at home?
Yeah, so this is where it's confusing, so you'll have to roll with this. But basically, FODMAP is an acronym for different types of starches and sugars. So it's fermentable oligo di mono something. You don't need to know, basically. But essentially what the diet is the whole premise of the diet is you're trying to work out which of these the individual is reacting to and which you need to reduce or exclude to reduce symptoms, basically. So that's essentially the premise of it. And as you rightly point out, is that this particular dietary approach has gained a lot of traction over the years. So there's been a lot of human clinical studies. It's been built into management guidelines and so forth. So in the world of science and medicine, it did go viral. And I think, the relevance of that like term applied to a medical intervention or, nutritional medical intervention is that maybe there is a bit of hype that we need to be questioning around it. Maybe it is like a viral phenomena, and we should be thinking about that, and in the sense that there might be other approaches or other ways of thinking about things that are not necessarily only a FODMAP diet.
Yeah, totally.
That's important. Yeah.
And we alluded to this a bit earlier, but only a third of people tend to respond to a low FODMAP diet, which is quite exclusionary in itself. What are your thoughts as to other things or other exposures that could be leading to IBS symptoms? Yeah,
so I think like winding it right back is when you have gut symptoms or IBS, which are really interchangeable in some sense, is you need to think, well, actually it's like there can be a lot of different causes, basically, and we know this is not controversial. It's what we call like a heterogeneous disorder, meaning that there are a lot of potential things that are aggravating symptoms for people, and the biology of it, like what's going on in your body and things like your microbiome and your metabolism related to that illness are really different from person to person as well.
Yeah.
So it makes sense then that there's not going to be a single solution. Like it's just not going to happen. Unfortunately, it'd be great if it did, but it doesn't. And so with interventions, whether it's a medicine or lifestyle changes or dietary changes or a magic probiotic or something like that, it's not going to work for everyone. You know, some people will respond because it fits what's going on for them. But the real trick is like working out what is going to benefit an individual and what is less likely to be useful. And that's the big challenge at the moment in medicine in general.
Yeah.
You know, is really getting better at personalization. And, you know, so that's the big picture.
Yeah.
But then the answer to the question is like, what are some of the other things is, you know, there are a lot. And, you know, I sort of divided into three general groups. One of them is nutritional things that could be contributing to symptoms. One of them is like lifestyle things. And the other one is like what we might call more like functional or metabolic things, like things that are happening in our physiology that could be that could help explain why we have symptoms. So it sort of wind it back to those three. And the nutritional piece we can dive into, but it's like there's quite a lot of different foods that could be aggravating symptoms, and there's also a lot of conversely therapeutic approaches that are very different that could help people. The trick is knowing who, and same with lifestyle. It's like there are lots of different things, but the big ones are like regular exercise. Sounds too simple, but it has a huge impact. Sleep and circadian rhythm is the other one, and stress management are like they're the big ones that are really important. And then in terms of the more intangible sort of functional things for people, it's like that probably in most cases are going to require some testing. So it's like things that are going on that we need to be looking for. Like, I don't know, one example is, an issue related to your pancreas that can be affecting enzyme output that could be contributing to symptoms, or it could be like changes in your gut flora that are contributing to symptoms in a specific way that we might be able to investigate it or
Totally.
So there's several examples like that, but that's the sort of thing I'm talking about.
Yeah, absolutely. I think anecdotally, I note that people tend to gravitate to the more sort of like sexy, for want of a better word, investigation-led approaches to figuring out their symptoms before doing the basic stuff.
Yeah.
And actually something that spoke to what you were just discussing, just mentioning here about lifestyle was the comparison of low-FODMAP diets versus yoga. There was a paper that you brought up with that, and it showed it was as efficacious. Am I right in saying that?
Yeah, I love that.
Yeah.
Like that was like, for me, that was just like, these sorts of things just open up some like serious questions, I think, is like, if this study for listeners is like you have a head-to-head comparison of a dietary intervention versus yoga, right? And they worked equally effectively. So for me that, I don't know, maybe I'm overthinking it, but for me that opens up like some serious questions like, which is the better intervention, firstly, like for patients. Maybe we should be giving them the option before you make radical changes to your diet. Yeah. Do you want to try yoga?
Yeah.
And then the other big one that is for me is even more interesting is like, how is yoga working? Like what's going on there? Does it mean that when you do yoga, you enhance your tolerance to dietary FODMAPs? Like, so can you skip the diet and improve tolerance to food by doing something like yoga? And it's not a crazy question because there are examples of interventions that do seem to be doing this. Is like they're actually enhancing your tolerance to your diet. Yeah. So these sensitivities, fall into the background, and these elimination diets become less necessary, which is cool.
Yeah. Which is really cool. The fact that you can potentially change your tolerance to these FODMAPs, but also your microbe structure or the community of microbes as well by exercise, which yoga is a form of. But even the stress relieving impact of something like yoga and the breath work involved in it as well could be having a demonstrable impact on microbial communities.
Yeah, absolutely. Yeah. And it, everything changes the microbiome, like everything. We were taught years ago that, you eat fiber and then it was probiotics And now what we know, it's everything. It's like basically the way you think, move, act, the environment around you, your pets, the people you live with, everything impacts the microbiome.
Yeah.
So it's, it's fair to say that there are a lot of different things that we're still learning about that could really change our gut function in ways that improve it potentially and mitigate some of these problems, not just the symptoms, but that intolerance to foods even, perhaps.
Yeah. Another popular diet that you mentioned already were as alongside the traditional diet or the PDA diet, you've got the low-FODMAP diet, you've also got gluten-free diets.
Yeah.
And gluten-free diets were really popular, and everyone's had that anecdote. I've had loads of patients before, like, I went gluten-free, my symptoms went away. I love gluten-free, and they stay gluten-free, and that's, it's great. If they can resolve their symptoms, brilliant. What I'm interested in is the why, particularly in patients who do not obviously have celiac disease. They have non-celiac wheat sensitivity. Maybe we can define exactly what that is and what might be going on.
Yeah, it's a really big question, and there's, we can dive into it, but there are still unanswered bits of this. And again, like to define so basically with gluten intolerance, you've got two types of intolerance, right? Is you've got celiac disease, which is really clear. And if you have gut symptoms, this needs to be ruled out. It should be part of the, your assessment is you need to rule out celiac disease. And that is, we can test for it, we can investigate it, and the treatment is really clear. It's like lifelong gluten elimination. The second type is where it gets murky. So we have this relatively newly defined phenomena called non-celiac wheat sensitivity or non-celiac gluten sensitivity. It's called different things, but the wheat thing gives away some of the complexity of this, which we can speak to. The problem with non-celiac wheat sensitivity is that the only way to identify whether or not you have it is really almost quite subjective and not very specific. So you trial a gluten-free diet for about 4 weeks or so. Again, under supervision's better. See if your symptoms improve, and then you can either, reintroduce to see if they come back or not. And, and that's basically the definition. We don't have a test. And the problem is here, we're talking about a food. No one eats pure gluten. So we can't be sure that it's just the gluten.
Yeah.
And the issue with wheat is it contains half a dozen other things that people could be reacting to that are really important. So they, although someone may think they have a gluten problem, they may not.
Yeah.
And that's not good because gluten is delicious and really nutritious and allows a lot of flexibility in your diet if you can tolerate it.
Yeah.
So you kind of want to avoid, strict elimination when it's unnecessary. So the issue is that there is these other things in wheat like FODMAPs, classic example. So for most people, like 80% of the FODMAPs they're eating in their diet are coming from wheat.
Yeah.
So technically a gluten-free diet is a low FODMAP diet, and it could just be that. So it could be that you've actually put yourself on a low FODMAP diet. You've responded really well. It's not the gluten, and then there are other things like enzyme inhibiting proteins and things in the wheat. Like I don't understand this very well, but there are other things that we think could be contributing, and then it gets a bit esoteric with things like the pesticides that are sprayed on the wheat and so on.
Yeah.
So but the short is we don't really know, and wheat's a complex food, and it gets sort of murky in terms of really understanding that connection quite well.
Totally, yeah. I mean, particularly when you think about the most sprayed crops. Certainly in America, where glyphosate is basically indiscriminately sprayed on so many different items, but particularly wheat as well. And we have an issue with pesticides in oats. That's why I tend to opt for organic where possible, but even that doesn't completely remove the likelihood of pesticide residues in your food. So there could be something completely other than a genuine intolerance or allergy to food elements going on that we're just not privy to because we just don't have testing.
Exactly. Yeah, that's exactly the problem. And and it's still open. We don't really know what it is. There are other things like the cultivars that, of wheat that we're eating today are very modernized. So the protein structures changed and so on and so on. There's like a long list, but at a really practical level, it's just hard to tease out basically.
Yeah.
So it leaves us with a conundrum where we don't know for sure. And I think the take home for people is like just to be really careful what you exclude and why.
Yeah.
And and if it is working for you, I would stress like try and reintroduce and see if you tolerate it, especially. And I think the thing with wheat, and you make great examples, is you want to look for organic, you want to eat sourdough. So like the quality and the quantity and these things really matter. Of course you're going to have a gluten intolerance if you wake up and eat a baguette with jam every day. Like, yeah. But it's not, it's a baguette intolerance. It's not necessarily gluten, it's just a really bad diet. So that, wheat in context can be really good for people. It doesn't need to be completely eliminated for everyone. So
have you come across people on holiday heading to places like Italy and trying the food over there and the wheat-based products and stuff and not finding any issues, but then they go back home and they're like, I can't deal with the wheat. It's something to do with the wheat.
Yeah, and anecdotally, I hear this a lot.
Yeah,
and I don't know what it is. I've tried to work it out, and I have no idea. And I think my gut feeling, excuse the pun, is it's probably partly the environment. I don't even know if it's the wheat itself, because it's all industrially produced in the global food system now, unless you're like buying wheat from an artisan local farmer. It's it's all kind of the same. But I think maybe just being in a relaxed environment and less stress and being on holiday and chewing food
definitely contributes to it. Yeah, absolutely.
That sort of thing will make a bit of a difference.
I find that even with dairy as well. So I have a friend of mine that went to America and he was convinced that the dairy in America is better for him. But I remember saying to him, I was like, I'm pretty sure that's not the case. But it's more likely the fact that you are stressed as anything, where he's a doctor himself, when you're working here in the NHS. And then when you're on holiday, like in America, you can tolerate it because your gut's in a better position.
For sure.
To digest what is likely going to be a poor quality dairy product, especially with his kind of diet. So
yeah, definitely. I mean, the dairy in the UK is great. It's all like grass-fed by definition, and you get to the States and it's like completely different. The quality's like
yeah. Have you come across these I actually think they originate in Australia. I think they're called GluteGuard, and they're gluten they're enzymes that you consume when you are about to go and eat some wheat-based products.
I know all about these. So I disclosure, I have a background in the food supplement industry and have been involved with these sorts of products. And basically there are a couple of, they call them gluten enzymes or gluten enzymes. Yeah. And they've been specifically developed to digest gluten. So there's a couple of them, about 3, that have quite good clinical data behind it. But the caveat is they're not for celiacs.
Of course.
They're they may help mitigate intolerance in people who are sensitive to gluten, like non-celiac gluten sensitivity. But even within that, I think what needs to be clear with those, it's not always on the pack, is that it's only really going to work if you're exposed to like the level of gluten that is more like inadvertent exposure. So if you're trying to avoid gluten, then you end up with like a bit of cross-contamination in your oats, or a crouton in your salad you missed. Yeah. Like it might help there, but you can't take them and eat a pizza. Yeah. It just doesn't.
Which unfortunately is basically how people are using them from what I've seen. Some people swear by having a whatever, I think it's GluteGuard or Glute Protect or whatever it might be. And then they go and eat a pizza and they feel like, anecdotally, better, no symptoms, no bloating, etc.
Well, if it's working, it's definitely worth trialing and seeing if it works. But based on the science behind it, like there is an amount of gluten that predicted to digest, and it's relatively small.
Okay.
Yeah. So pizza, no. maybe a little bit of, something by accident. Yeah,
Gotcha.
That's fine.
What are the enzymes? Do you remember what they are?
Yeah, the trade names on two of them I remember. One of them is called Tolerase G.
Okay.
And that's sold by a number of different brands. And it will be at the dose that matches the clinical trials in the products. It's part of the, the way they formulate it. And the other one is, I can only remember the research name, but it's A&E PEP. I can't remember the trade name on that. So, but Tolerase G is fairly easy to find in different brands. Yeah.
And is there, in your opinion, is there good clinical evidence about the efficacy of these? It's with the caveat that it's only for accidental.
Within those, it's pretty good, and it's important to be aware of, because there are gluten enzyme products on the market that don't have evidence. In fact, they've been tested. There's at least 2 publications, one in PLOS Medicine, where they took products like this off the shelves, tested their ability to digest gluten, and most of them won't do it at all.
Oh, wow.
Which is like so misleading and concerning.
Yeah.
So you just, look for something like Tolerase G. The other one I'm trying to remember, it might come back to me, but there's about 3 that have clinical data that back it up.
Okay.
Yeah.
On the subject of clinical data, elimination diets.
Yep.
Really, really popular, particularly amongst the functional medicine community.
Yeah.
Not very popular amongst registered dietitians, nutritionists accredited with AFN. Why don't we talk about what an elimination diet actually entails and how they're currently being utilized at the moment for patients with gut predominant symptoms?
Yeah. No problem. So there's different definitions of what an elimination diet is, but I know where you're going with this. And what we're really speaking to here is like these kinds of dietary approaches where we're eliminating multiple foods for a period of time and then often reintroducing to see if there's tolerance. It's really how they're generally constructed. And there are 2 camps or 2 ways of implementing these. One of them is like an empirical traditional approach. So what that means is that you don't do any testing, basically. So you give the patient guidance or on how to implement this, give them some dietary, rules and, tools and so forth. And they go off and they eliminate all these different foods and then you slowly reintroduce to test and see what happens there. And the other type is like a testing-led approach. So there are a lot of different tests out there that lead this sort of approach, but the best evidenced is IgG testing. So that's a food antibody type testing done with blood. It can be a pinprick test, not necessarily a lot of blood required, but there are others as well. There's like a leukocyte antigen assay test, and there's another one that's really strictly sort of in the research world at the moment. It's a focal endo. I can't remember the full name.
Yeah, I remember
it's like a camera.
Yeah. That was wild when you showed me that. It's using gastroenterology at the moment, right?
Yeah, it's used in research only. in gastroenterology research, and it's really cool. And I think it's worth mentioning, even though you can't get it.
Sure. Yeah.
Because it sort of proves that the concept is sound. It's like a really robust test because you're looking at it in real time. So what they do is they, with endoscopy, they get a camera down into your digestive system, and at the same time they expose your gut epithelium to an antigen from food like soy, wheat, dairy, these things we commonly react to. And then in real time, they watch the gut mucosa react to the antigens, and they can, if you're reacting to it, your gut mucosa pulls apart and you get what we call leaky gut or intestinal permeability. But basically it's an immune reaction, strong one, to the food antigen. And the cool thing is with this is that they're able to demonstrate that this approach clearly identifies responders to an elimination diet.
Right.
So if you base your elimination diet on this test, it works really well for reducing symptoms in IBS.
For example, it's a lot more specific.
Yeah.
In terms, and you can actually demonstrate what's going on.
Exactly. Yeah.
And it's cool. we'll pull it up for the folks at home. This is from your presentation. It was a graphical abstract from Gastroenterology from 2019. It's called confocal laser endomicroscopy.
That's it.
Yeah, it's a bit of a mouthful, but fascinating. I've never come across that.
Yeah, it's really
before.
neat. And for me, you know, and this brings us back to the things that are more relevant to clinical practice and accessible to people, is that it, in part, sort of suggests that there is something to what we're doing.
Yeah.
But the problem is the you know, the things we have available are not as, you know, robust in a sense. So, you know, we can't use cameras and live antigen exposure in a clinical setting yet. It's too invasive and complicated and so forth. So really what we're stuck with is these old school approaches like don't even test, is just try it and reintroduce and then the testing piece. So to speak briefly to those, like the approach where you don't test actually has like old scientific foundations. It was pioneered here in the UK as an approach for IBD, with a little bit of work in IBS. There was a great gastroenterologist called John Hunter who was involved in the publication of this work at I think it's Cambridge. He was there,
Gotcha.
and basically. It's the problem with that approach is all the data is really old. Like it's like you have to go back in the literature like 20, 30 years before you start hitting it.
Right.
And then there's loads of it.
Yeah.
But it's really, and no one wants that kind of evidence because it's not like the quality we have these days.
Sure.
It's too dated. Everyone wants something in the last 5 years or whatever. And, you know, so it gets really overlooked. But the funny thing about it is it was adopted early on in like alternative medicine, like functional medicine, integrative medicine,
Gotcha.
you know, naturopathic medicine, and so on. And basically, it's still used today routinely in these kinds of practices because it works. Anecdotally, it seems to be working, and you know, so I think that shouldn't really be dismissed. What we do need is more evidence and more investigation of it as an approach to really justify its use in clinical practice, because there are people using it in the real world and it seems to be helping people.
Yeah.
Not to say it's, you know, not an ambassador for it or anything. I think we need to investigate it more, but it, you know, that's where that's at today. And then the other approach is like the testing-led one, which is a proper minefield because of the testing.
Yeah.
So the problem is with the testing is it's controversial for a few reasons. One of them is that everyone has IgG antibodies all the time.
Okay.
Even people without IBS.
Okay.
So like, how do you explain that?
Yeah. Yeah. Because if maybe we can explain what an IgG test actually involves.
Yeah, cool.
Because I think people might have seen the words IgG or food allergy test online because everyone's been bombarded by it on Facebook ads and stuff. But then we can go to the controversies as to like what happens when you do one. Just a quick one. If you're enjoying this kind of content, you will love our free newsletter called Seasonal Sundays. It goes into depth on a seasonal ingredient every Sunday, and we talk about the nutritional medicine benefits, the research, and the culinary uses of an ingredient every Sunday with recipes included. You can get access to the free newsletter in the link just down below.
Yeah, so what it is a really good question, especially for people out there, because there are a lot of different types of food sensitivity testing. And what I would advise people to do is, if you are looking at it, is be really cautious of what kind of test it is, because some of it's really wacky stuff and really unevidence-based. But if you go into IgG testing, like that's a very specific type that does have some foundation behind it, and that's what we're talking about. So what it involves is like a little blood test. It can be done with a finger prick test. You sort of fill a little vial, send it off to the lab. And then what they do is they come back to you with a rating scale on what you're reacting to. And what they're testing in the lab is the level of these IgGs, which are like little antibodies. So it's theoretically, it's your immune system reacting to the food.
Gotcha.
In theory, but controversial.
Yeah.
And generally what you'll see is you'll have half a dozen or so of those that come up as potentially problem foods. You pick the top ones. Usually it's only the top 3 or so, and you start there and you eliminate them and then reintroduce them over time to see if you tolerate them, and that's how it works basically. So that's the background behind the test. And in terms of the research behind it, it's controversial in terms of its how it works. Like I said, everyone has IgG antibodies. There's problems with the research that does exist, and so on and so on. But my take on it, and I say this from the perspective of looking at the literature. I haven't formally reviewed this topic or anything, but what I can say is that in areas like IBS, but also IBD, like inflammatory bowel disease, and migraine headaches. Weird, to link those 3, but there are quite a few studies of these types of tests in those 3 areas. And what you generally see across all the clinical research is some sort of positive clinical response.
Right.
Now, the issue is that the clinical response is not very strong, and the quality of the data, the studies themselves, is not very good. But you do see a trend towards improvement across all of these, and I don't think anyone can really refute that.
Sure.
So from my side is, I think, well, there looks like there's something there. People are responding positively to it, and I don't think we can dismiss that just saying the evidence is not good enough. We need to say, well, maybe it could help people, and maybe we need better evidence and to better understand why and what's going on, and to untangle those controversies as well.
Gotcha.
So I'm kind of for them, but as a last resort.
Gotcha.
So on the scale of like things to prioritize, it's way down the bottom. But I think for some people, they can potentially be useful with those caveats, around the controversy and accuracy and clinical useful-ness and so on.
That makes sense. I think that's a really balanced viewpoint on them. I don't have first-hand experience of either using them or prescribing them. But I wonder if they're, again, like the kind of studies that we like head-to-heads. Is there a head-to-head study with a traditional elimination or restrictive diet versus one that is IgG guided?
There is actually one recent one head to head against the low-FODMAP diet. For people with IBS. And the IgG testing performed way better.
Really?
In terms of clinical response.
Interesting.
Yeah, that one's been hidden under the covers. But but it's also quite recent. So it's not, but that's the only one I'm aware of. But that was interesting.
That is interesting. And just to go into the controversy a bit more. So like if I was to take an IgG test today and it looks at, let's say, I don't know, some of these tests are like 200 plus foods that will tell me whether I'm intolerant to them or not. And I don't identify as having IBS type symptoms. I don't bloat, I don't have any issues with my mental well-being or fatigue or anything like that. And it shows up with certain foods that are quote unquote red for me. Is that indicative? Is that truly indicative of an intolerance, or is it a false positive?
It's really hard to say. And this is one of the challenges with this approach is that, and this is one of the controversies in favor of this type of testing is that food sensitivities aren't just about gut symptoms.
Gotcha.
So most of the work in this area is like looking for people with IBS, and maybe what we have been calling false positives are actually adverse food reactions that are linked to symptoms that we're not thinking about, like depression or anxiety or headaches or fatigue or something like that.
Or skin dryness. I do have skin dryness actually.
Right.
So,
Big problems.
That's
good. And like on a practical perspective, for someone like you, there's not an obvious issue related to a food sensitivity. I would say, you really want to question this before you embark on an elimination diet. Is it even going to be valuable for you? Probably a waste of time. But at the same time, if it's not difficult for you to try it, it would be super interesting because who knows, like something that niggling like skin dryness or some other issue you hadn't paid much attention to could resolve, because food's linked to everything, right?
Absolutely. Yeah. And on the subject of intestinal permeability, I think one thing that you has described quite eloquently is leakiness is normal. That should be happening at meal times.
Right.
It's the excess of intestinal permeability, as it's defined in the academic literature, where there are problems, where it can lead to hyperactivation of your immune system, excess LPS, all these different markers of poor gut health, rather than the presence of leakiness in and of itself.
Yeah, absolutely. And I think in that whole area, that's a really important thing for people to understand is like when we talk about leaky gut, it sounds like there's a hole in a bucket and water's spilling all over the floor or something.
Yeah.
But actually in physiology, in our gut, function, it's normal. There's a physiological element of leakiness that's completely normal. And it's mostly in response to eating and exercise, and maybe stress, I guess. But it's totally normal to have that. So I think, it's like the demonization of a process, like inflammation is a similar story, right?
Absolutely.
It's like a bit of inflammation is good. It's totally normal, happening all the time. Same with your gut, and it's like that. So, this whole fixation on leaky gut needs to be treated with a degree of caution, and it probably needs to be defined and contextualized as a problem before you start worrying about it.
Yeah. Absolutely. Yeah, I completely agree. Are you aware of any studies or consumer reports where they've done a sort of an examination of all different types of tests? Like one person has done a test from all these, like, I don't know, 4 or 5 different companies, and looked at the results and see if there's actually a consistency across the results.
Yeah, no, there's not. And, I would love to see something like this and one of the problems is it depends a bit on the test, but if you're looking at like gut health and function, there's so many different biomarkers out there. Like, and the best example of where this is probably never going to match up is like the microbiome, because the labs use different techniques and methods, and they're measuring different things sometimes. And then the human body changes all the time as well. So some biomarkers will be quite robust and they will stick across labs for sure.
Gotcha.
And we know that because of the way they work and their validation and so forth. So if you test, for example, like fecal calprotectin, which is measuring inflammation, it really should match across labs. If there's not a match, there's something really fundamentally wrong with the lab probably. But it's, some things will just jump around because and this is a problem with labs in general, is people think they're infallible numbers, but they're not sometimes, depending what we're measuring. There's a degree of, movement and error and, I'd be really interested. I might even do that experiment myself. I mean, these are quite expensive tests. I think they go for like 120, 130 quid each. But if we were to line up 5 of them and I was to use the same finger, the same blood draw at the same time, and then look at them and just see if there's consistency across the results of what I'm potentially triggering an IgG response to. That would be an interesting experiment. But if one says I've got these 20 ingredients and then another says these 50, which are completely different to these 20, there's something going on there. And again, as a consumer, I'd have no idea which one to trust. Exactly.
So that's an interesting one. I've even found that I did a little experiment myself with continuous glucose monitors. So I had a Dexcom in one arm and I had a Freestyle. It was a Freestyle Libre in the other, and I checked my my blood with using the gold standard BGM, a BM monitor. And the Dexcom is better in my opinion because you can calibrate it.
Right.
Whereas the Abbott you can't calibrate, and there was a difference of about 1 millimole, which is huge. Which is a big difference. So, and again, that's my own experience. It might not be the same for anyone else. Depending on a whole bunch of factors that I can't really explain, but it's just one of those things about like testing in general that I don't think many people, particularly outside of this field, appreciate much.
Oh, for sure. And it's a huge point is that you want to be really careful about basing big decisions on tests. Basically. It's, it really needs to be brought back to the context of that test and that result for the person. There's an old saying is like, don't treat the test, like treat the person. And that really speaks to that. And that's a great example is like, you're going to see different results from different labs. And, if you've gone off and based your whole diet on a lab result. Like, it's like,
I remember something that was something
dangerous.
It's really dangerous. I remember something. One of my first bosses in medicine taught me that, like, it must have been like 15 years ago now. When I first came across an erroneous potassium result on a patient, I remember running. I was like, oh gosh, I need to look at like hyperkalemic guidelines, and I'm gonna, like, start treatment straight away. And he was like, don't treat the result, treat the patient. I mean, there was an erroneous result because of a lab, actually. And I remember learning that lesson very early on, and be like, always question like the validity of this and compare it to the physical symptoms of a patient before you do anything. And I think the same thing would apply when people are now exposed to those labs at home. It's just something to be aware of.
Yeah, absolutely. It's a really good point for people who are testing at home is just to be really careful. And one of the dangers with home-based testing and direct-to-consumer testing too is that there's no filter. And the problem is that these are commercial entities that are selling a product. And for them, the big marketing claim is the value of that product. So they're going to say this test is accurate. This test tells you something really useful. But those two things may not be true.
Totally.
Or maybe more nuanced.
Yeah.
So you need to be really careful what they're claiming their test does. And the challenge is it just sounds so legit. It's like it's a blood test and it's going to a lab. Guys in white coats are like doing this, scientists.
Like, you go on most websites and they've got literally tick, 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 all those different things. Like it's going to this lab. The lab's either based in Oxford or Cambridge. So you have the association with the university, even though it's not coming from the university. And you've got an image of somebody with a lab coat and all the ticks and, all these sort of like certificates of authenticity and all that kind of stuff. So you can see I think I'd be more comfortable if a test was coupled with a consultation with a genuine practitioner,
for sure,
who could interpret them for them. Because I think allowing a population, no offense to anyone listening to this who isn't from a scientific discipline, is just like it's fraught with dangers, because you can overinterpret. I mean, people develop anxieties from just Googling things, let alone getting their own investigations and trying to interpret themselves.
100%. And it's really dangerous water, and there probably should be regulations around it that limit that. Another really good example that is a bit of a pet peeve of mine is like breath testing for SIBO.
Oh yeah.
Because the thing is like with this particular test, just to explain.
Maybe we should explain what SIBO is.
Yeah,
actually,
cool.
Because I wanted to talk about SIBO and anyway, so this is a great jump off.
Cool. Yeah. So SIBO stands for small intestinal bacterial overgrowth, right? And it's a really controversial area, basically, in the area of digestive disorders. So the standard sort of line, from a commercial perspective, and this comes from labs and people selling products and stuff, is that you can do a breath test. You can identify, this problem. It's overgrowth of bacteria into the small intestine, which then ferment things and cause problems and pain. Very, the picture of IBS. So you can identify this on a breath test, and then you can manage it by doing a SIBO diet or taking some pills or probiotics or antimicrobials, natural ones or whatever. And you'll get better and that'll be great. So it's like a perfect commercial system, test, product, recommendation or whatever, and then management. But the problem with it is the test. So the test, as in medicine, we call it like specificity and sensitivity. Yeah. Basically, it's really poor on both of them. So that means it has real problems with accurately identifying small intestinal bacterial overgrowth. And this is really key. And it comes back to your point about, managing the patient, not the test. And the danger with SIBO testing is that linked to a positive, which may not be positive, can very likely be false on a SIBO test, is people base whole strict dietary regimes on it, and they embark on like antimicrobial therapy and so on when they may not need to. And your point about people developing anxiety about Googling is for sure, like we don't have data on this, but for sure people are developing eating disorders around SIBO testing. Like I just think this must be happening because the power of like doing a test that's then you're being told that it's definitively telling you there's this problem with like bad bugs in your gut that are feeding on things you shouldn't be eating, and you've got to do this, and it really needs to be filtered through a healthcare provider, because there is some potential value in it for some people.
Yeah.
If it is, if those limitations are we're aware of them, and we've got a practitioner who can sort of filter that information and manage it appropriately and communicate those limitations to the patient.
Yeah.
But it's, for direct-to-consumer testing, I just think it's like one of the worst offenders. Yeah.
What is actually being captured in these breath tests? Because there's a bunch of other breath tests now that are looking at markers of health with specific regard to metabolism as well. So you blow into this device, it tells you you're mainly burning carbs today, or eat some more carbs. I'm sort of like bastardizing the commercial video that they've probably got on their websites here, but there's people probably know the products that I'm talking about here, where you blow into it and then. But so what are these breath tests actually measuring?
So these ones are measuring two main gases. It can be either or a combination of both, but they're assessing breath hydrogen or breath methane, and these are gases that are produced by gut bacteria, and you're breathing into a device, and essentially they'll test for the level of these gases after a challenge of something that will provoke them, like glucose.
Gotcha.
Yeah.
So that's in a similar way to an OGTT, an oral glucose tolerance test.
Exactly.
You have something that's highly fermentable, consume it, and then you breathe out a fixed amount of time afterwards, and it measures whether it's above a threshold or below a threshold.
100%. That's what's happening. Yeah.
Okay.
Yeah. So,
and do we have a clear idea, perhaps not because it is a controversial area, as to what is driving small intestinal bacterial overgrowth?
Yeah, so it's an interesting one, because the history of small intestinal bacterial overgrowth is good to understand, because historically the definition was a little bit clearer. So we had a criteria that was like, if you had chronic diarrhea and vitamin deficiencies and things like B12 that we know are part dependent on a healthy gut, and a positive result on a different kind of test. It was a jejunal aspirate culture. So it was before breath testing. Right. That's what was utilized. Is like that would be possibly SIBO, and then it was managed with vitamin therapy and dietary changes and antimicrobials, drugs and so forth. But where this really got murky is like when breath testing came out with its low accuracy and was applied to like IBS, basically, and that's where it really gets a bit sort of vague. What we think is probably going on is that it will be the case for some people. It's just the test is not very good at like identifying exactly who is the problem, relevant to, or who has it, I should say. But if you do have it, and you've gone through good care and you've had testing, and we think this is what's going on, is if you've asked the best question, is like, what's causing it? Because that's the thing we need to understand. And there are lots of potential different causes is the answer. So it could be happening related to your gut function. So one of the things that we know is potentially contributing to it is like changes in gut motility. So like if you have constipation, in particular, that could be part of the picture of like driving this overgrowth in your gut, because things are not moving through, and it's giving the bacteria an opportunity to like move around and colonize areas they shouldn't, and start digesting things where they shouldn't be in the small intestine. So that's like one classic example. Another one is
and just on that point, you can imagine patients trying to self manage constipation by having a lot more fiber rich foods, and then that exacerbating their bloating symptoms and SIBO. Exactly. So that's the sort of pattern that comes to mind straight away.
Yeah, absolutely. And this is a big thing, and one of the reasons also we think that some people are intolerant to fiber is that it's the small intestinal bacterial overgrowth is underlying. And so that's interesting. And then it could be something like excessive alcohol use is a key driver. It could be certain medications. The classic example is if you're on antacids, that's a really quick way to establish SIBO is starting a prescription of antacids. So that, and we've known for years they can contribute to IBS-like symptoms. So it seems to be part of the mechanism and so on. So they're like some of the key things, I think.
Yeah. Anything in the diet other than alcohol, like high sugar consumption?
Yeah, good point. And yes, so observational studies suggest that dietary sugar is a thing. Okay. So and that just all fits perfectly, right? Because we've also seen this sort of observational data link highly processed, refined, and particularly sugary foods to IBS-like symptoms. So and then mechanistically is like you've got an easily fermentable substrate for gut bacteria that's straight into the small intestine. So of course, it gives these microbes an opportunity to colonize and start fermenting sugar. Yeah, basically.
Yeah. And on the subject of microbes, so one of the treatment modalities, I believe, is antimicrobial therapy to try and remove these pathogenic bacteria, relieve symptoms, and then you sort of recolonize. But I guess what happens is people fall into a pattern of having to have multiple antimicrobials again and again because the symptoms go away and then they come back and they go away and they come back. Yeah. Is that something that you've got experience in either treating or seeing what's a more effective way of
it is a big challenge. Like when you look at what they call relapse rates with antimicrobial therapy, it's really high. So basically you get like acute symptom relief during short-term prescription and then it just comes back most likely. How do you manage that? We don't really know the answer to it at the moment, but what's happening out there in the real world is people who are dealing with SIBO are looking at just like logical, pragmatic approaches to keeping symptoms at bay. And typically this will involve like, some of the diets we've already spoken about. So it's like trying to find a diet that fits the patient to help relieve their symptoms. A popular one that's utilized along the management of SIBO is a low-FODMAP diet. Okay. Because it's also restricting fermentable substrate and fibers. So, it seems to be helping and then following up the course of antimicrobials with things like probiotics and fiber and other like healthy eating recommendations and so forth. So it's sort of like we've got an acute opportunity to try and get some symptom relief, but we need to get on it to try and keep those symptoms at bay. And that's sort of just, a bit of everything really. Yeah.
You're just sort of like throwing things at the wall really hard. Pretty much. With a lot of these. And in terms of a SIBO specific diet or the SIBO diet, are there any characteristics that differentiate it from a low FODMAP diet or a...
Well, the thing with a SIBO diet is there isn't one. So, like from the sense of... an established, studied diet, there isn't. Like no one has ever looked at this, which is what's crazy because there are SIBO diets. Like there are books, there are recommendations from labs. There are people talking about it, people using it, following them. But there's nothing in the scientific literature to support this. There's some recommendation or suggestion as well that a low FODMAP diet would be quite suitable. And a colleague of mine published a nice little case study. It's one of the few, it's just a case study, but it's one of the few pieces of actual evidence we have published suggesting that when they used a low FODMAP diet alongside antimicrobial therapy, it really helped.
It kind of worked, okay.
But, beyond that, we've kind of got nothing. But the anecdotal ones that are out there are really different and really diverse. And I would advise caution against using them because some of them are really restrictive as well. Like, and they're just based on ideas, like they've never been tested. Yeah. So I think if you're going to do it, like, with a practitioner, try low FODMAP maybe, but beyond that, we just don't know.
Yeah. And you mentioned antimicrobials and I always, obviously with, overprescribing and greater awareness amongst the medical community of ensuring that we're not overprescribing antibiotics for obvious reasons, antimicrobial resistance, etc. Do you find benefit with herbal therapies or other supplements with antimicrobial action that are, for want of an unscientific term, like less hardcore than your full blown antibiotics.
Yeah, anecdotally they seem to work. Like a lot of people are using them in practice, and again, like the caveat is like little evidence. There's like literally one half decent study from Johns Hopkins University. It was Jerry Mullins' group.
Oh, okay, yeah. Jerry Mullins, who is a presenter at the conference, Nutritional Medicine conference.
Yeah, right. So his group published some work showing that a herbal antimicrobial approach, when compared to a drug-based approach, seemed to be as effective clinically, or at least as effective, and actually a bit better tolerated in these sorts of patients with SIBO. So there is a little bit of support for it, and to your point, I think it's a good one, is that these sorts of approaches we think are probably a bit safer, a bit better tolerated, and certainly less likely to develop resistance to a drug that we might really need.
Absolutely.
When we really need it. So there is that. But again, it's a bit of we just don't know.
Totally.
The other question I have around this whole thing is that herbs are multi-action, right? So the herbs we use as antimicrobials traditionally, like in Ayurveda, the andrographis and wormwood in European medicine, is like wormwood is an amazing anti-inflammatory. It doesn't just eradicate microbes. So you're giving these patients something we don't really know what it's doing. So is it really treating SIBO?
Yeah,
maybe, but it's probably doing lots of other stuff as well that could explain why people are improving.
That's
probably a good thing.
Yeah, that's the really interesting thing about herbal medicine in general, is that because you're using the entourage effect of these whole plants or derivatives of plants, you don't really know whether it's the antimicrobial action, the anti-inflammatory action, the sort of like anti-motility action that could also be helping with the constipation. So there's all these different things that are going on. And I think on the wider question of like experimenting with these antimicrobial herbs versus antibiotics is probably the one playground that I think is relatively safe, because you wouldn't want to try herbal recommendations for a chest infection, let's say, that could spiral out control into full-blown sepsis and lead to someone going to the ICU. At least with SIBO, that if you try something and it doesn't work, it's not going to lead to like a case like sepsis, which is going to obviously have potentially life-threatening outcomes.
Yeah, absolutely. It's a really good way to put it. And when you're dealing with something like trying to relieve gut symptoms, there's not a lot of harm in trying it. I mean, theoretically, it could be disrupting your microbiome like an antibiotic does.
Yeah.
So long term, you want to be careful with it. But a course and maybe 2 courses is not a lot of risk.
I don't think I haven't come across anything that like C. diff related cases with antimicrobial. Did Jerry's group publish what herbs they used?
They did. So they used about 4 different products. They're all US based. Unfortunately, but they're very much like the kind of products that we use here. And their approach is really interesting, as they cycle it. So the way they do it is if you get a positive breath test and the symptoms fit and they think it's appropriate, they try a 4-week course. And then if that product doesn't work, they switch products, try another course and see if you respond to that. And then they stop. So I think it's a really good pragmatic approach and makes sense. And it's also reassuring to know the kind of products they use is like a lot of
what we have.
Formulas that are out there.
Great. Histamine.
Can of worms.
Histamine is another can of worms. Like we're basically descending now into the really sort of like murky world of therapeutic diet. So histamine diet's very, very popular. We put this to the community of like the kind of therapeutic diets that people have come across or found benefit with, and low histamine diets are pretty popular. Maybe we could talk about what histamine actually is and where we find it. From my understanding, it's pretty ubiquitous across everything we eat.
Yep.
But there are levels and spectrums of how high histamine a particular food is.
Yeah, definitely. So histamine is like a protein, a component of the human immune system, and it's involved in particular in like what we would call like atopic type immune functional reactions. So atopic is like allergic, but includes things like asthma and sensitivities and allergies and rhinitis and skin, rash and reactions. So that's sort of what it is in the body. But the thing is it does also exist in food. So the same, protein is found in a variety of foods, but it's like you say, it's in everything, but it's particularly high in certain foods, like fermented foods is a great example. And then some like preserved meats and
canned fish. I think tomatoes or certain
it's possible.
It's a random mixture of foods. It's not like one category.
Unfortunately not. It's really all over the place. And there's this thing called histamine intolerance, right? And I think really important to define it, because there's what I'm seeing is a huge amount of confusion around this everywhere, and it's sort of being overgeneralized. So I think defining it's really key. But histamine intolerance is an issue we've known around for a long time. It's been in the scientific literature for a long time, quite obscure, but it's gained a lot of traction in recent years. And what the concept is that some people seem to have difficulty metabolizing histamine in food, and that is provoking a histamine type reaction in the body that looks a bit like an allergic immune type reaction. So it doesn't necessarily mean that someone develops asthma, but they could have wheezing symptoms. And it doesn't necessarily mean they've got like a really bad rash, but they might have a bit of urticaria or itching or redness. And where this has become really topical recently is it's started to be generalized out to be linked to other things like IBS, like gut symptoms as well. So there's a lot of interest right now, and there's a couple of research groups looking at this, is trying to tease out the relevance of this to common gastrointestinal symptoms and see if some of the approaches we know to support histamine tolerance actually work for people where it might be an issue.
For sure.
With IBS, basically.
So is there any evidence for it at this moment, in your opinion? Or is it like
there is, and it's really suggestive and preliminary, but there is support for the idea, basically. So what seems to be happening is that in probably a subtype of people who have IBS is that histamine might be a problem. Who we don't know, how many, and the frequency we have no idea. But there does seem to be a suggestion of this. And the reason we know this is because, or we think this, is because histamine does play a role in some of the symptoms of IBS. I mean, it arguably plays a role in everything. So that's a bit of a weak link. But it also, has been picked up by a few clinics that are trying to like isolate people that have have evidence of histamine intolerance. And what they've done is like tested some of the traditional management approaches for histamine intolerance in patients with IBS like symptoms. And they're seeing a good response in some people. So what are the approaches? It's like a low histamine diet is one, which is like, again, like, it's a sort of a vague, restrictive, complicated, thing. And then the other approach is like giving a supplement. So there's a supplement that helps you digest, basically, or break down histamine called DAO or diamine oxidase. So it's an enzyme used to manage histamine intolerance. And a group in Graz in Austria and another group in Barcelona in Spain, and they're looking into this, and they're seeing in patients that this kind of, find the people who have evidence of high histamine production or histamine intolerance. So they look at like a sort of their clinical symptoms. They look at some testing that's available, and then they're also looking at like response to intervention. And what they're suggesting is that there might be something to this in the area of IBS. But again, really preliminary.
Yeah.
Difficult to do. Like you say, the diet's really complicated.
Yeah.
So it really does need to be under supervision, I would say. And but I think there's something to it, but it's early days.
I've got a couple of follow-up questions on this, and I appreciate it's still very preliminary. But from my understanding of excess histamine production or intolerance to certain high histamine foods, it can be a real constellation of different symptoms, right? So one of which is IBS, some of which the sort of typical histamine-like reaction like urticaria, so wheals or itchy skin, hives, that kind of thing. But even migraines or arrhythmia,
for sure,
fast heart, irregular heartbeat, that kind of stuff.
Yeah,
it can be really, really far-ranging. So for anyone who has any sort of vague symptom like that, for them to go down the histamine route, you can imagine it being quite attractive and it being like, oh, I've got that symptom. Maybe it's histamine. Let me take histamine out of my diet. Is that something that you've come across yourself?
Yeah, and it is a thing. So the constellation of symptoms related to histamine intolerance are very non-specific and vague. And that is a problem when you have potential therapies that are based on vague non-specific symptoms.
Sure, yeah.
Because those symptoms can be caused by lots of different things that may have nothing to do with histamine. But there is a constellation that is suggestive. It's like you say, migraine is a good one. That seems to be a big thing. And on top of that, the allergic atopic type symptoms and IBS-like symptoms. So those things fit a kind of histaminergic type picture. And then it may be worth exploring, if that's sitting there. And it can really help people. Like I've seen some great case examples of people, their lives have changed after, identifying this, usually themselves, because it's not something that's on people's radar, and it's very non-specific. And, we're still, even just the concept of managing histamine intolerance in the English medical literature is really new. It's been around in Eastern Europe and Russia for decades, but it's only really getting traction in the last, I would say, 5 to 10 years maximum. So it's people are not spotting it. It's being overlooked.
Within the migraine community in particular, I don't know whether it's been explained through the histamine intolerance paradigm, but removing things like aged cheeses, alcohol, yeast-based products, that fits a sort of like anti-migraine diet that again is being sort of like has been promoted in the past. Even through established resources, a lot of practitioners recognize that a lot of people have issues with those kind of products.
For sure, ask
them to take it out of the diet. Resolution of a lot of symptoms.
Yeah.
So maybe that can be explained through histamine.
I think it potentially could be. Like the thing with migraine is a lot of the traditional dietary approaches that are used, like these, the classic elimination foods, are based on just experience. So it's more just like, we think these probably work, and they seem to for some people. And we've often rationalized these as being like related to other things in those foods like tryptamine.
Yeah.
But you're absolutely right, as it could equally be histamine.
Yeah.
And there are good clinical interventions of like low histamine diets and DAO enzyme in patients with migraine that are really suggestive of a good clinical benefit in people where that fits. It's not, migraine's not always a histamine problem, but it can be for some people.
In the same way that DAO, what's it called? DAO oxidases.
Yeah, diamine oxidase.
Diamine oxidase.
Yeah, DAO is
the supplements that are used to break it down. What about antihistamines? Would they work in a similar way?
It's theoretically, and there's been some experimental trials in people of antihistamines for patients with IBS.
Gotcha.
And there seem to be responders. So like if you look at the cohort they tested, is like some people have no benefit, but some people had a really good clinical response. So it is really, suggestive that for some people there's a histamine problem. But as far as I know, those have not been, sort of brought out into clinical practice. It's more experimental work.
And the DAO oxidases, you can tell I've got hay fever. Have they been used for people who have general allergic symptoms?
Yeah, so there's quite a few clinical trials on DAO for migraine in particular, but also IBS-like symptoms. So the group in University of Graz, Austria, are like, for me, them and the one of the leading groups that are looking at this at the moment, they have run a clinical trial of DAO enzyme in people with IBS-like symptoms and saw a really good clinical response. But then, they've also long been used for management of histamine intolerance in general. So it's worth a shot. Like if you do get hay fever-like symptoms, like can't hurt, costs you a bottle of pills. If you respond, that's great. But my experience with antihistamines, and you'll see the same with medicines, is it's hit and miss.
Totally.
Like some people respond well, some don't.
I can't take any antihistamines. They all make me drowsy, even the non-sedating ones. So I've gone through loratadine, cetirizine, all of the different types of antihistamines. I've obviously prescribed them in the past, all that kind of stuff. But for me, never had a very not a tolerable side effect profile that warranted the resolution of symptoms, and even the resolution of symptoms wasn't that great either. So I've unfortunately not had. And we've done deep dives into like hay fever dietary therapies actually to see if there's anything out. The closest we've come to is like green tea, an anti-inflammatory diet, probiotics, but very, very limited research on that. And that's about it. And it's just green.
Pretty much. And then there's like a few dietary supplements like quercetin and bromelain but like you have to take so much of it, super expensive, and it doesn't work for most people.
Actually, it's interesting, isn't it? Bromelain, which is that enzyme from pineapples, I think papaya as well. Because I have come across some ENT specialists, so ENT surgeons that prescribe bromelain supplements when they're doing like rhinoplasties or
for recovery.
For recovery.
Again, there's clinical work on that. Like it's been used in dentistry for years, like to complement surgery, because it reduces the swelling and speeds up recovery. Like no one knows about this, but it's amazing. You're seeing specialists who are using it. That's fantastic.
In conventional medicine as well. It's brilliant. We need to get more people on the supplement train for those kind of
prescribing pineapples. Great.
Look, I could have another conversation with you about supplements. I think we'll stop there. But man, I've learned so much about therapeutic diets today. I know you've got another conference coming up later on this year. We'll link to that in the show notes as well. But I would love to do this again and do a deep dive into supplements, because I know that's your background. That's what you spent most of your career looking at. And we were talking off air about like determining what a good supplement is, what a good supplement brand does, and also lab testing in general. So we'll have to do another episode on that if you're around.
You provide the herbal tea, I'm in. It's all good.
Great.
No, this has been really fun, and I really appreciate being on the show and sharing this stuff with people. It's really valuable, I think, and hopefully it empowers people. Oh man, the pleasure's all mine. Thank you. If you loved that episode, you will love the full library of podcasts from the Doctor's Kitchen Library. We talk about everything from inflammation, supplements, and food as medicine. Just like this episode right here. You can click it right now and check it out.